Okay, thank you, JIBIN, for a very brief welcome. So I once again welcome all the speakers as well as the participants here. This is our third webinar since the COVID problem has been gripping us, and now for the last 3 months we are doing it consecutively. The next month the meeting will be chaired by Binny John, our additional professor and vascular surgeon, who would be talking about the ischemic limb. So we always plan 1 month in advance, and that should mostly be on the 9th of next month, 9th of February. So I would like BIJU to straight away start the proceedings of this session on gallstones. And although JIBIN made an introduction, I think the participants were not able to identify each panelist. So as BIJU is making a slightly bigger introduction, I think each panelist can come up and say a few, maybe a word or so that your video comes up on screen so people can identify each one of them. Thank you very much. Over to BIJU.
Yeah, good evening and welcome to all, and thank you very much for organizing this panel discussion on gallstone disease. I myself, BIJU from JIPMER, Puducherry, an old alumni of Kottayam Medical College. And today we have a very eminent panelist and experts in this field. Dr. AJO John is a senior consultant in St. Mary's Hospital, Newport, UK. He's a HPB surgeon and a minimally invasive surgeon. And Dr. T.D. YADAV is a professor of GI surgery at PGI Chandigarh, and he's also a secretary of the International Hepatopancreatitis Association Indian chapter. And I welcome Dr. AJO and Dr. T.D. YADAV. Welcome, sir. Dr. VARGHESE is a very eminent personality in minimally invasive surgery, and he is the president-elect of the Association of Minimal Access Surgeons of India, and a very leading minimally invasive surgeon. And he works at GEM Hospital, Thrissur. Welcome, sir, for this panel discussion. And Dr. AMIT GOEL is an additional professor of medical gastroenterology and very aggressive interventional endoscopist, works at Sanjay Gandhi PG Institute of Medical Sciences, Lucknow. Welcome, Dr. Amit. Yeah, I request all the panelists to unmute and on the video. Yeah, so we'll start with some very common problems, and I will pose the questions to panelists for next 1 hour, 15 minutes. And I will select the most appropriate panelists to begin with. So other panelists can also contribute regarding this. So let me start with Dr. AMIT GOEL. He's a physician. He sees the patients in huge crowds. So many people want to know, what are the gallstone related symptoms? Is there anything called biliary colic, or is just a misnomer? Let us say a patient is coming fresh. No ultrasound, nothing. Nobody told us that there is gallstone. How exactly, what will be the symptoms to suspect a gallstone disease, and what exactly is biliary colic? Can you please explain that?
Thank you, Dr. BIJU, for giving me this opportunity to interact with such a nice and excellent educated team. Really, this biliary colic is a completely misnomer, because the traditional or the classical biliary pain, it is never a colicky pain. It is a continuous type of pain which starts in right upper quadrant, gradually, most of the time it gradually increases in 15 minutes to half an hour, reaches to its maximum intensity, then plateaus at the same level for several hours, usually for most of the time up to 30 minutes, 1 hour, most of the time less than 6 hours, and then it wanes off. In between the pain, the person is completely asymptomatic. Probably that is the reason why it is named as colic. Because whenever there is an episode of pain, at that time person is in agony. But in between the episode, person is completely asymptomatic. Typically, the pain can disappear suddenly if the stone which is causing pain has fallen back into GB or gone down into CBD or has passed out into duodenum, and then pain will disappear, and probably that is the reason it is misnamed as colic, but it is not a colic actually. Typically, this pain happens after heavy meals when GB tries to act and try to pour the bile into the duodenum, and in that effort, GB stone is stuck in the neck of cystic duct or somewhere in CBD. That is typically it causes pain. So after heavy meal at night time, typical pain, other than pain, what are the other symptoms which are commonly associated or considered to be as a part of stone disease are dyspepsia, commonly considered as, along with the gastroesophageal reflux disease, reflux symptom primarily, bloating, heaviness. These kind of symptoms are considered, but they are not related with GB stone. These symptoms are otherwise so much common in general population that whether it is really related with the GB stone or it is just the part of their high prevalence in the community. So scientifically, they are unrelated with the gallstone disease. What the classical symptom for gallstone disease is pain in right upper quadrant, which comes in episode. Each episode lasts for less than half an hour to few hours. Gradually, pain reaches to the peak in 15 minutes or in half an hour. It stays there for an hour or two, and then wanes off in short period of time. That is what is classical for GB stone.
So what I was asking is one more clarification we need. The symptoms you are told are mostly related to some other diseases also. If those symptoms, especially the postprandial pain you are suggesting, are finally found to be associated with gallstone, that patient should be considered as a symptomatic patient. Are we understanding this correctly?
Yeah, postprandial pain, but it is not the timing of pain, but the location of the pain and the nature of the pain. It is a continuous type of pain in right upper quadrant, which is lasting for say 30 minutes to 1 hour or 2 hours. And in between the pain episode, person is completely asymptomatic. That is much more suggestive of gallstone, because the association with the heavy fatty meals, it is very poor. You will get this kind of history in 10 to 15% of people only, not in higher percentage.
Okay, so by proper history taking, you will be able to differentiate a gallstone related symptoms present or absent. Am I correct? That's what you are trying to tell?
Yes, with
yes. So with 90%.
Yes, with in large majority of proportion you will find, because there is hardly any other differential diagnosis to it, where the pain is coming in episode, and then in between the episode person is perfectly all right. The in acute condition, actually sometimes it may be get confused in emergency situation with the myocardial infarction or ischemic heart disease.
Okay.
There the major differentiating feature is, if a person is having myocardial infarction or ischemic heart disease, person tries to stay calm and don't want to move at all. In the contrary, in a person with gallstone disease, if the pain is related to gallstone, person will be tossing on the bed. He will not be comfortable in a silent position, because he is searching for a position in which he is comfortable.
Okay.
But in case of myocardial infarction or ischemic heart disease, person will try to not move at all, so that there should be very minimum pressure or load, oxygen requirement on the heart. And this is the major differentiating feature between the ischemic heart disease, a major differential diagnosis for the gallstone.
Okay. One associated question to that, to Dr. Amit only. So we find dyspepsia as a common presenting symptom in this patient. Dyspepsia means many people just diagnose a group of symptoms or symptoms are dyspepsia. So is it associated with the gallstone disease actually?
it is not associated with gallstone disease because dyspepsia is so much common. Something around 15-20% people have dyspepsia. And as the age increases, the gallstone disease prevalence also increases. By the age of 50 years, you will say at least 30-40% of the population may have some evidence of gallstone disease or small size fevers stones. So dyspepsia is not associated. The studies has also shown that they are not associated with the gallstone disease.
Okay, fine. So I want to check with Dr. AJO. So normally you order, everybody orders ultrasound examination. Okay. So when you order an ultrasound examination for a suspected gallstone disease, as Dr. Amit pointed out, what exactly you are checking in the ultrasound examination in your clinic? For example, what you will tell the radiologist, this question is to Dr. Ajo, what exactly you will tell the radiologist to check? What are the things? Something like a checklist for ultrasound examination in gallstone disease.
The gallstone disease, first of all, I should agree with Dr. GOEL, because the history is the real key to the diagnosis. So when you have this confirmed this biliary colic as a, in my words, it is the kind of heart attack pain of the abdomen. So the message I am trying to convey to the sonologist would be this biliary type upper abdominal pain, and I would be looking for gallstones. So my request would be specifically to check for the gallstones. So I would be interested to hear about the what is the presence of gallstones or thickness of the gallbladder to show whether it is acute cholecystitis, and if the sonologist is that experienced, I would expect mentioning the description of common bile duct, portal vein, and also the hepatic parenchyma. So I wouldn't be expecting anything more than that in an ultrasound scan in a suspected gallstones.
Okay, if the patient is coming with you, let us say you want to manage it surgically, any other additional information you will ask, or from the ultrasound only?
In a typical patient, if the symptoms are typical, like, if you are convinced that it is a biliary colic, the history, again, I have to reinforce the history is really important, because if the history is really conforming to the biliary colic, the central upper abdominal pain, which radiates across the abdomen, sometimes it radiates to the back or between scapula, associated with the nausea and vomiting. This is a typical presentation of the patients we see here. Okay. And if that is a typical presentation, most of the time I tell patients it could be gallstones. And if the ultrasound scan would be the first examination. And again, also, if you are suspecting biliary colic, you would also request for the LFTs. And if the ultrasound scan didn't show what I was expecting, and still I suspect it is gallstones, I may ask for an ultrasound in a different time.
Okay, that's a very important point. We need a clarification regarding that. So you are telling that you give more weightage to the proper history.
Yes.
And if you are suspecting the gallstone in a very high probability, you will do additional investigation. The suspicion is very high.
Yeah, suspicion is high because that is clearly based on a clinical history. Okay. Because if I hear any unusual symptoms, like a weight loss, patient had altered bowel habits. Very few, a small proportion of patients can have altered bowel habits with the gallstones. That is very rare, but small proportion. That is not a common. But the issue is if there are any other symptoms which points to another disease like acute pancreatitis or pancreatic pathology, then you would be doing another investigation. But the symptoms and the clinical presentation are typical that of biliary colic in a good proportion of patients with gallstones. They will have the typical presentation. And if the ultrasound scan didn't answer your question, you would I would ask for another ultrasound scan, not far away, but in maybe a couple of weeks after, or within a month.
Okay, another ultrasound. Okay.
Another ultrasound scan. You know, you can even go for a US if your suspicion is very high.
Oh, you go for US also if your clinical history-wise suspicion is very high.
Yeah, you're clearly suspecting, because obviously sometimes these patients can present with abnormal LFTs, had an episode of pancreatitis, because that is different, because the, you know, the gallstones, we are talking about biliary colic, so I shouldn't be deviating to other entities. But if your suspicion is very clear, then, you know, the next thing I will be, based on my clinical assessment, another ultrasound scan.
Okay. So, Dr. TD, I wanted to ask you a very specific question. You belong to North India, Chandigarh, and you have done a significant work on a different form of gallbladder disease presentation. When will you suspect a malignancy in gallbladder? Can you just summarize and tell the clear points?
First of all, thanks a lot for the Kottayam Surgical Society to giving me this opportunity. There is weather in Chandigarh is not good, so I was having problem in my net. So I have gone back to mobile network, Wi-Fi disconnected. So I could not hear properly what Dr. John said. But as you are hinting towards something else, so apart from good history, what sometimes in North India it's difficult to differentiate classical gallstone disease with some sort of malignancy happening in the gallstone disease associated. So what is important is to know, go into details of history more. Suppose there is some sort of associated aversion towards food, meaning thereby appetite loss, pain has changed its character, more frequent pain and not classical colic and giving relief after taking some medication, but it is frequency is increasing. Then going to the weight loss, it may be little bit extra, but if history doesn't point to anything towards any type of malignancy, then on ultrasound would like to see very clearly every time we mention that, please mention the thickening. If there is a thickening, what is that thickening? What is the size of stone? Then what is the size of common bile duct? Is there any thickening is circumferential? Thickening is focal, is irregular thickening, or thickening is regular as it is present in a benign disease. So all these points we want to clarify and to the ultrasonologist. And it's difficult sometimes to differentiate in the very early period. But here in North India, especially in Chandigarh, we have to be very careful, and we request radiologists to also be very careful in reporting. So these are the extra points. Maybe, as I said, I could not hear properly. So these are the points we would like to say. Any sludge is very alarming. Suppose there is a sludge, then we ask our friends in Medica PGI, go back and see whether there is add some Doppler. Is there something enhancing in the sludge? If sludge
can you explain that point? If they are suspecting a sludge, that sludge may be a tumor. That's what you are trying to do?
Yeah. That in North India, sludge is very, so all the incidental gallbladder cancer, we are finding, we send a paper also, mine presently it is in World Journal of Surgery. Whether they are accepting or not, we don't know. But incidental gallbladder cancer we have reported. And we have said, are they really truly incidental? Because people ignore. In North India and in East India, as you know, differentiating gallbladder cancer differentiates north, south, west and south, north and east, and northeast also. So here any polyp more than 1 centimeter associated with this stone, any sludge in the gallbladder which is present there, any pseudo tumor, people are very fond of describing it as a pseudo tumor. But when these are the present there, we try to explore more into the history, try to ask them whether any type of loss of appetite is there. Even if it is not there, then in PGI we ask our friends to do one more Doppler add to the ultrasound and try to see. Otherwise, immediately we proceed to this radiology higher investigation, like going for the CT scan. So our threshold to do a CT scan is very low in a North India. And as I said, if there is a focal thickening, if there is irregular thickening, if thickening is of more than 4 to 6 centimeter. Our paper published recently, where we have found that it's thickening, even it is isometric, circumferential isometric thickening more than 8.5 millimeter. The association with the malignancy is more than 90%. So all these factors we try to investigate and try to took into the account when we are seeing a patient of gallstone disease. So this is what we would like to have at that particular time.
Okay, thank you. So I want to ask Dr. Varghese 2 questions. The first question is malignancy of gallbladder a concern in South India? Do you see any patients like that and some odd symptoms? Do you keep that diagnosis in your mind in gallstone disease anytime?
Yeah. First of all, let me thank Dr. BIJU for inviting and Dr. SUNIL and the Kottayam surgical team for this panel discussion. Regarding the question what you raised, I think that in South India, the incidence of the gallbladder malignancy is definitely low compared to that of North India or Eastern India. But we do come across occasional cases in our practice. So I think that we should be alert and we should be vigilant about this, and we should be concerned about this possibility of missing a gallbladder carcinoma. So always when the patient comes with for example, we have actually in a couple of our cases have made the diagnosis after the surgery. But all these cases, there's a gallbladder wall thickening and it was diagnosed as acute cholecystitis. And
these patients you are diagnosed retrospectively after surgery, correct?
After surgery.
Okay.
So here actually, otherwise we should make all the attempt to make the diagnosis before surgery itself. As mentioned by our panelist, that I think that it is the gallbladder wall thickness more than 10 millimeter. I don't know, there could be difference. Mentioned that 8.5 above is taken as suspicious of malignancy, but in some papers they say that it's about 10 millimeter should be taken as suspicious about malignancy. And irregular thickening or focal thickening or the polyps more than 10 millimeter in size, etc., always should raise a possibility of malignancy. And always the malignancy being associated, we know that nearly 80 to 90% cases is associated with the stones, that are big stones. So the stones more than 3 centimeter in size, definitely even it calls for a prophylactic cholecystectomy because of the concern of malignancy. So bigger the size of the stone and any wall thickening and no significant symptoms like acute cholecystitis, always we should bear in mind that malignancy should be ruled out.
Okay, so it's a concern in South India and Kerala as well.
Yeah, definitely.
Yes, okay. The second question I wanted to ask you, you might have operated hundreds or more thousand patients of gallstone disease. So what are the other diseases commonly associated with gallstone disease you see normally? You might be operating for some other indication or some other disease they are suffering, or let us say example of peptic ulcer disease, and that patient had gallstone. Any other associated diseases you want to consider?
That is actually now obesity is one of the like bariatric surgery. Where there is a concern about whether there should be prophylactic cholecystectomy should be done or not, because these patients when they rapidly lose weight, there is a increased chance for the formation of the gallstones and the symptoms later on. So especially in patients who undergo gastric bypass surgery, prophylactic cholecystectomy is concerned. And of course, in cases, if it's not at all related, like patient coming for hernia surgery, there could be gallstones. But generally, we don't operate if it is asymptomatic.
You don't operate if it is asymptomatic, even if the patient is undergoing anesthesia? Yeah.
In a case of hernia, usually we don't operate. But in a case of bariatric surgery, that too in a gastric bypass surgery, prophylactic cholecystectomy is done.
Okay, so can I ask an extended question to that? Suppose, let us say a patient is under anesthesia for some other surgeries and all that. Let us say totally unrelated surgery like hernia still is in the abdomen, and there are gallstones, and it can be easily tackled by laparoscopic cholecystectomy. So patient is posing you a question that why can't you do it in the same city? Let us say renal stones, hematuria symptomatic. Now we have a gallstone here. What will you do?
No, usually our policy is not to operate a symptomatic group of patients. But at the same time, if the patient is very keen and the patient is undergoing another surgery, definitely that will be discussed with the patient, and then in those cases, we may consider a surgery for cholecystectomy.
Okay. Dr. AJO, this particular point I wanted to ask you, what is the policy you follow? There are some totally different indications. Let us say renal stone. That patient is under anesthesia for surgery or another percutaneous intervention. Do you operate that patient if they don't have symptoms?
Unless patient has got here good number of patients above 50 years have got gallstones. Unless there are any symptoms you can relate to gallstones, or the patient had some consequences of gallstones, we wouldn't consider operating. Obviously, yeah, we don't consider, because good majority of the patients have got gallstones, especially above the age of 60. So we don't.
Okay, Dr. TD, actually, here is the same question posing to you. You have a different problem altogether. So, do you consider this as a chance to remove the gallbladder if there are stones, if the patient is asymptomatic for stones, because of risk of malignancy?
Normally, no, but as I said, we would like to do one more ultrasound, and from
no,
PGI.
everything is normal. Only stones are there. Patient is asymptomatic.
Normally, no. Other than the textbook, what is textbook recommendation about transplant and all those things, patient where you are going to have a prolonged TPN, all those things are textbook indications. Otherwise, we are not. We don't operate.
Okay, you don't operate. Okay, so it's most of the panelists. So risk of malignancy, even North India, you don't operate. Okay, Dr. Amit, I wanted to ask you, what exactly is an incidental gallstone? What exactly is the meaning of that word?
Incidental means the person is completely asymptomatic. He has been evaluated for some other reason, and the most common reason is dyspepsia. And routine ultrasound found that gallstone is carrying 1 or 2 stone, and that is the reason why dyspepsia is considered to be associated with gallstone disease, because both things are very prevalent, gallstone disease as well as dyspepsia, and most of the stone disease are asymptomatic. They are incidentally detected on an ultrasound which was done for some other indication.
So the common problem for surgeons is they will ask a very specific question always. Nobody undergoes ultrasound without any symptoms. Yeah. Okay, so the patient is coming with an ultrasound with gallstones, as you already explained the symptoms and all that. So according to you, the symptoms has to be again completely reassessed. Am I correct?
Yeah. Actually, what the best thing could be, because first time, suppose some mild symptom, dyspepsia, GERD, bloating, for which ultrasound was done and a stone is identified, it's better to counsel the patient and ask him to keep an eye and watch for the pain. But if the pain is, so now because there is a pretext of possibility of stone disease, probably person can better describe the biliary pain, which is of milder intensity, and we can keep an eye, watch for 6 months, follow up. If the symptom in next 6 months, 1 year, you find out the symptom is more suggestive of stone disease, then you can go for surgery. Otherwise, and you have given medication, suppose for dyspepsia, proton pump inhibitor, prokinetics, antihelminthics, and many times actually dyspepsia is associated with constipation, which is very common and not recognized also. And the symptom has gone, then there is no need for surgery. We can avoid the surgery.
Okay, so Dr. Ajay, I wanted to ask you a question. Which patient you select for observation, watch and wait policy?
Just
what you clearly told no typical symptom. Who else? Let us say patient has diabetes but gallstones and no typical symptoms.
There are 2 varieties of patients. One, you found gallstones.
Okay.
And we believe that this patient's symptoms are not due to gallstones. Okay. Those patients, we leave them alone. Unless the patient, there are some relative indications like going for renal transplant or renal transplant patient with cirrhosis, but that is different. But we take the usual cohort of population. So the patient with no symptoms, leave them alone. And the second cohort is a patient who has got symptoms, but their symptoms are not that frequent and not that severe, and they want to. It's their patient's choice. So even though I offer them cholecystectomy, they opt not to go for cholecystectomy. They want to watch and wait. So these are the two categories. I would be happy to leave them alone.
What about diabetes? Just presence of diabetes.
Diabetes, it was considered as a risk for patients who have got gallstones, but large studies haven't proven that, because nowadays diabetes are well controlled with newer medications, and it is like any other disease. Diabetes is not a risk we consider for doing cholecystectomy. There are many patients with diabetes who have got diabetes. The gallstones are common in diabetic patients, probably because of their metabolic syndrome, but it doesn't mean that they need to undergo cholecystectomy.
So diabetes is, as such, is not an indication.
Not an
indication.
Panelist
is still following diabetes as an indication. Dr. VARGHESE and Dr. TD.
No, I think the diabetes is all time we used to consider diabetes as an indication for cholecystectomy, but not today.
Not today.
Dr. BIJU, actually, just one point I want to add, because most of the diabetic patients are type 2 diabetes, and which is most common in 5th, 4th to 6th decade, and that is the time when the prevalence of gallstone is quite high in the society, at least in India. So you can again say there's a false association between the diabetes and gallstone disease, and the only concern with the diabetic patient is that they can develop, once the cholecystitis, if it develops, then it can be life-threatening. There's high risk complication, but not high incidence of acute cholecystitis. If it happens, then the risk of complication is high.
Okay, fine. So, Dr. TD, I wanted to ask you, you have done ultrasound, you have diagnosed the gallstones and all that. So, when exactly you are going to do a CT, MR or MRCP? What will prompt you to do? One indication Dr. AJO told us is a very clear unequivocal symptoms. Ultrasound is not delineated stone he wants to do. But when exactly you will do a CT, MR or MRCP? Here is a proven case of gallstone disease.
No, I think as I said in the beginning, there are now there are two components of your question. So MRCP in gallbladder proven, if you suggest, then probably there are a scoring system. You have to see whether with gallstone, what is the size of the common bile duct, as it is taken at about 5 millimeter normal in less than 50 years, and then beyond that it can be up to 6. And then liver function test, any history of jaundice earlier, or history of cholangitis, history of acute pancreatitis, if it is there associated with gallstone-induced pancreatitis, even if there had not been any much deranged liver function test, but sometimes there are soft pointers, sometimes there are very pressing pointers to do a cholangiogram before going for surgery. But this is the part where I said MRCP because suspicion of this common bile duct stone, 10 to 15%. But when I am coming to the CT scan, as I said, CT scan, our threshold would be, I think, much lower than many people who are seeing it. As I said, we want to err towards having one extra CT scan than missing a gallbladder cancer. So if there is a thickening which is focal, if it's associated with stain, if there is a polyp with a stone and more than one centimeter, if there is a thickening which is not symmetrical, if there is a thickening which is probably more than 5 millimeter. We would like to see all those things. And then if there is any chance of some lymph nodes around in the hepatoduodenal ligament on the ultrasound, then again, we would like to have a CT and these differentiate CT and MRCP indications will be little bit different. As I said, I was very particular about pseudotumors people describe. The radiologists are, I think, are the key. And if they have a prepared mind, the chances of missing the gallbladder cancer would be lesser. So we are finding many amazing things even in this area where we are trying to have multiple CME, but doesn't help. So if you, the moment they see something in the gallbladder, the radiologists are very fond of advising correlate with FNAC. And suddenly they will go for FNAC. That is usually we want to discourage. Even if you are saying people go ahead with the do. So if there is a mass lesion, pseudotumor, if there is a sludge, also sludge is again very important association with the stone. In North India, I would like to have more investigation if we are finding a sludge. Not that we are going to operate upon it, but we would like to correlate each and every finding when there is this type of features, rather than thinking that this is a stone disease alone. And then proper history is also very important. The people where about 15% benign disease our extended cholecystectomy has been done. So we are finding retrospectively that these are the people having probably almost no symptoms, but they are having radiological suspicion because of the, as we have very strict criteria. So we have more prone to go for other investigation, try to resect. And as you are aware that extended chole straightforward without CBD excision usually have no much morbidity or life-threatening complications. So our we are towards operating more. But these are the people where history is also very, very important, as emphasized by you and other panelists in the beginning, that we must go and ask them particularly about any symptom. Are you losing weight? Have you think that appetite has decreased? So we are probably very particular about this. So this would be my indications. Suspicion of malignancy, which is suspicion of the common bile duct associated stone.
Okay, Dr. Amit, I wanted to ask you an extended question. Today, let us say today one patient came to my OPD with gallstone disease. Now he is showing me a LFT report around a month back with a bilirubin of 2.4 and alkaline phosphatase of 320, and otherwise other investigations are normal. Do I need to do MRCP or evaluate the common bile duct for this patient? And what is the reason if so?
If it was 1 month ago, yes, then we have to correlate with the symptom at that time when the LFT was done. Because at the time of biliary colic, when the stone was obstructing the biliary tract, there is a possibility of mild biliary LFT derangement. Right. So if he was asymptomatic at that time, when LFT was done, then the abnormal LFT carries much more weightage than at the time of symptomatic disease, right? If he was symptomatic when LFT was abnormal, I will like to repeat an LFT and repeat an ultrasound, because there might be transient obstruction which has caused this derangement of LFT and alkaline phosphatase. So I will like to repeat LFT along with GGT, because most of the alkaline phosphatase, most of the stone disease are in 40s, 50s, and most of us are vitamin D deficient, which can be the cause for alkaline phosphatase elevation. So I will like to do GGT also, gamma glutamyl transferase, to know whether the origin of alkaline phosphatase is from bone or from liver, and also like to see ALT, AST, and bilirubin elevation. So I will like to do a repeat LFT and a good quality ultrasound with information provided to the sonologist that earlier his LFT was abnormal. Please specifically look for gallstone disease and common bile duct up to lower end. If there is any suspicion on ultrasound, repeat ultrasound or LFT, then I will like to go for endosono or MRCP.
Okay. Dr. Ajo, I wanted to ask you, let us say the same patient, now the liver function tests are normal. We ought to do a cholecystectomy. Will you do an intra-op ultrasound or intra-op cholangiogram for this patient?
BIJU, could you repeat
the so the
previous
patient
part
is coming to OPD now. With a 1 month back, he underwent a liver function test which shows bilirubin 2.4 and alkaline phosphatase is around 380. And after the repeat ultrasound showed a normal, and the repeat LFT showed a normal value. CBD is normal on ultrasound, and repeat ultrasound is done. CBD is still normal. So this patient is a intraoperative ultrasound or cholangiogram is indicated.
BIJU, I would again ask you what were the symptoms of the patient.
Yes, that's what Dr. Amit was telling.
The patient. Okay.
That time there was no clinical jaundice and pain was there.
No, the pain, no pain.
Pain was there.
Pain was there. Was biliary type pain.
Yes.
Biliary type pain, and the ultrasound, the first ultrasound scan was normal, absolutely normal.
No, ultrasound showed gallstone, but common bile duct was normal.
Normal. Okay, so the patient has got gallstones, and the LFT abnormal, transient abnormal LFTs. Now it became normal. Yes. Okay, my practice is that this patient will go for a laparoscopic cholecystectomy and intraoperative cholangiogram.
You will do.
Yeah, intraoperative. Any patient who has got a history of abnormal LFTs with the gallstones, I will do an intraoperative cholangiogram.
Even if it becomes normal later?
No. Yes, I will do.
You will do.
Yeah, I will do, because I don't have a data to show, but I have, I got a very unusual experience one occasion. This is a 27-year-old lady who came by jaundice, became jaundice, went to gastroenterologist, full investigation, showed gallstones, and she didn't have a MRCP, so the LFTs came back to normal, totally normal. And then referred to me for because they did all the gastroenterological investigations, fibroscan, everything was normal, only gallstones. Referred to me for cholecystectomy. So I did an on-table cholangiogram. Her bile duct was full of stones. So that is not common, but the issue is that still I find maybe 1 or 2 stones in the bile duct, which obviously is not causing any abnormal LFTs, but stones are there. Around 10% of the stones will not show any abnormal LFTs. So I always do intraoperative cholangiogram for all patients who have persisting abnormal LFTs or had abnormal LFTs.
Dr. Varghese, do you stick on to the same stand or you want to?
No, I would be going on the current scenario rather than what happened in the past. Because we know that many times that the stone, even if it has been documented that is there in the CPD, if it is small, it can pass off into the duodenum. So we see that, then later on, they may not have any problem related to the bile duct. We don't have to do any intervention as far as the CPD stone is concerned. We have to just do a cholecystectomy. So our policy of doing a cholangiogram is on a selective cholangiogram. But we don't, I think in this present, the case, what you said, that 1 month history, 1 month back patient had an abnormal LFT, right now it is normal. Yes. I would not be considering an intraoperative cholangiogram in this patient because there is nothing to show or suggest that there is an evidence of stone in the bile duct. If there is some evidence like CBD dilatation, as has been mentioned earlier, that diameter of the CBD has been increased, or any suspicion of any stone by ultrasound, definitely then we would be going for an MRCP in this case, and before taking up the patient for the surgery. And MRCP also shows that either stone is there or no stone. Based on that, we'll be taking. If the MRCP shows no stone, again we won't be going for a intraoperative cholangiogram. But at the same time, if the MRCP is showing a stone, then the decision has to be taken, whether it is to be tackled endoscopically or by laparoscopically.
Okay, so you will prefer an MRCP is a highly suspicious scenario.
Yeah, but not taking the patient straight away into the surgery.
Okay. So
but our policy of doing that intraoperative cholangiogram is very, very limited.
Okay. Very limited.
Because
okay.
most of the groundwork would have been done before the patient taking into before the surgery itself by investigations.
Okay, so okay, understood, sir. So next we'll discuss very two specific, little bit controversial scenario. I want the opinion of all the panelists in this specific issue. You have gallstones, you have CBD stone. This patient was symptomatic. Okay, so you have a gastroenterologist who is well experienced in endoscopy at your center. You have a surgeon well experienced in laparoscopic CBD aspiration at your center. Both are available. Okay. So in that situation, what exactly you are going to do in a patient with gallstones as well as CBD stones? Let us say a 1 centimeter CBD stone, single stone in the bile duct. I'll start with Dr. TD first.
So first of all, I will talk about our policy. So our policy is all CBD stone are being managed first by gastroenterologist, and only if failed, then we go surgical management. And
so it is a policy. It is a policy.
Yeah, it is a policy. And you know the institutional problem also, because of the high load of the benign diseases are neglected in the institutes so far. So even gallstone diseases, we are rarely able to perform laparoscopic gallbladder surgery. So the question is that one. But if you go by the literature, then I think there is enough evidence that both go hand to hand. Complications, if you start complications, they are almost same. If you see the success rate, they are almost same. The hospital stay in a ERCP and laparoscopic cholecystectomy, which when compared to CBD stone one time, then it is a little bit more. Conversion rate is little bit more in probably significantly different, but rest of the things are almost same. So most of the people, if there is a very experienced person, people say in earlier there were some reports like Puducherry, you say the report they showed that if one time cost was lesser, but nowadays it has been shown that cost is also same almost. So it's depends on the expertise available and somebody is doing. So
okay.
I think
yeah. Okay. Let us pose this question to Dr. VARGHESE. Dr. VARGHESE does many CBD explorations. What will you do if the patient is directly coming to a next consultation room? There is a gastroenterologist. You know he can take out any CBD stone.
Now, our hospital, we are doing both, like endoscopic as well as the laparoscopic. So what we actually divide the patient is that if the patient has got small stones and the duct not much dilated, etc. In those situations, the endoscopic approach is preferred. Whereas if the patient has multiple stones, big stones, dilated duct, etc., then the laparoscopic approach is preferred. So we take up the patients based on this finding. And also the failed ERCP and the stones still in the CBD, those cases also been taken for the laparoscopic approach.
So you have a policy and you select the patients.
Yeah, we divide the patients.
Otherwise, they will go for endoscopy.
Yeah, we divide it between some patients go directly for the endoscopy. But here in our hospital now, we started doing the endoscopic as well as the laparoscopy, both under the same anesthesia, simultaneous.
Both under the same anesthesia. Okay. Let us. Yeah. Okay.
That is another advantage. If it is there is advantage or plus also minus also regarding that. But two anesthesia or two sittings can be avoided. Can be done in the same sitting.
Okay, so the same question is posed to Dr. Amit. And now, as you know, he does a lot of endoscopy intervention. Even in 2 centimeter stones, sometimes in CBD, they may do ESWL and break the stone multiple attempts, take it out and all that. So what is your consensus view in this aspect? Where will you stop if the patient is coming to you? Obviously, I assume that you will not refer to an expert lab surgeon in the first to go. You will refuse to refer.
I fully agree with Dr. Varghese. We have to be, if I'm doing endoscopy, it doesn't mean that everything should be cleared with endoscope. So if stone are multiple, and especially they are big, especially more than 1.5 centimeter, and practically it's likely that the person is going to need more than one sitting of ERCP. Then it's better to go for surgery directly instead of doing repeated ERCP to clear the CBD.
You are anticipating a multiple intervention first.
Exactly.
Okay.
So if we are anticipating that more than one sitting of ERCP may be needed because of multiple large stones, or suppose then we have to go for, better to go for surgery in the same setting. But if we feel that the stone is up to say 1.5 centimeter, 1.2 centimeter single stone, other stones are smaller in size which can be removed, the larger one can be broken down, and then we can go for first ERCP followed by surgery.
Okay. Dr. Ajay, I want to ask you the same question. What is the evidence-based approach in this?
So both ERCP and laparoscopic cholecystectomy or cholecystectomy and CBD exploration both have got outcomes same, but the laparoscopic cholecystectomy and the laparoscopic CBD exploration is considered to be more cost effective because it will avoid 2 procedures and reduce the cost, reduce hospitals, etc. But the outcomes are same. So I would, unless the patient has got a multiple gallstone, multiple CBD stones and dilated CBD, that patient is a straight indication for a laparoscopic, an operative management, laparoscopic cholecystectomy and laparoscopic CBD exploration if you can clear it. But if the patient has got a single or 2 or 3 stones in the CBD and gallstones, I would send the patient to a gastroenterologist to clear the bile duct. A minority of the patients, their symptoms will completely disappear after this CBD clearance, and they may not even require a cholecystectomy. So therefore, my option would be in a patient with a limited stone disease in the bile duct, who recently became symptomatic, and your investigation showed gallstones and CBD stones, I would rather send the patient to a gastroenterologist first. And there is another proportion of patients who became symptomatic recently, either by jaundice or a biliary pain, have got CBD stones, and the ultrasound scan and the imaging didn't show any stones in the gallbladder. They, in my opinion, they don't need a cholecystectomy. Their CBD clearance would be enough. That is the treatment. They became symptomatic because of the stones in the bile duct.
So you are suggesting that if there are no stones in the gallbladder, there are stones in the bile duct, just do a CBD clearance. And also you are telling that there are some indications where gallstones and CBD stones are there. You can clear the CBD by endoscopy and wait also.
Oh, wait and see. Yeah, because those patients, the symptom may be due to the CBD stones, not the gallstones. There is a trial going on in the UK. So when the trial is completed, we will know more about whether all the gallstones need to be treated. Because
I think that's
even in my practice, I have seen few patients who had a jaundice or who had a recent biliary pain. Their investigation showed a bile duct stone. As a traditional practice, we all send the patient to gastroenterologist first for a clearance, and the gastroenterologist then bounce back to me for a cholecystectomy. But then, when the patient comes to me, it will be another 3 months. So patient will say, "Doctor, I didn't have any problems." Then what do? They don't need an operation.
Yeah, that's a very interesting and probably a very to be discussed or innovative point where you are trying to relate the symptoms to the common bile duct stones, and again you are trying to observe the gallstones. Am I correct? That's what we.
Yeah, true. But bit cautious about the young patients with the multiple gallstones. Even if they are asymptomatic, they can become symptomatic. But that is just young patients with multiple gallstones. But bit older patient with 1 or 2 stones in the gallbladder, I would still, if the patient is asymptomatic, it's important asymptomatic, I would tend to leave them alone.
Okay, fine. So I think there's some very innovative points came in this discussion. The next controversial point I want to ask Dr. VARGHESE. A patient has acute cholecystitis. Okay, now it is diagnosed on ultrasound, symptomatic and all that. When will you operate? Will you operate this patient or when will you operate? If so, or let us say elective cholecystectomy. What is your exact opinion? Can you give very crisp points regarding this? Your practice, your safe practice.
Yeah, I think that what you want to discuss about early surgery versus the delayed surgery. Like in acute cholecystitis, now we know that there are two schools of thought. One to go for early surgery, that is within 72 hours, or delayed by 6 weeks and then do the cholecystectomy. But I think that it has been shown that the early surgery, the morbidity is much less, and we can, with the expertise of the laparoscopic surgery available today, the early surgery is found to be very beneficial. But in practice, what we see is that many times the 72 hours, it's very difficult to calculate. The patient would have had multiple episodes of pain or episodes of pain, or what is the duration of this episode of acute cholecystitis. This all becomes very difficult. So nowadays, certain units, including ours, the policy is that as soon as the patient comes, that we offer surgery. Whether it may be 1 week, it may be 2 weeks, or it may be 3 weeks, or it may be 3 days, or 148 hours, or just 12 hours. So at the first sitting only offer the surgery, and with the expertise available in 99%, I think it will be that surgery can be done safely without much problem. So I think that that is our policy now. Rather than we don't go for a delayed surgery unless in cases where, now if you look at the Tokyo classification grading, the grade 3 cases where there is so much sepsis with the organ failure, or the patient becomes high risk for the surgery because of the other reason like cardiac or etc. like that. In those cases only we consider delay the surgery or go for a drainage first and then delay the surgery. Otherwise, in all other cases, we offer cholecystectomy at the first.
Okay, but I have a problem with that. I'll just pose what is my problem, I'll tell you. So all the proponents of laparoscopic cholecystectomy, acute cholecystectomy, when you take out their series of cholecystectomy, there are a lot of variant procedures done. Subtotal cholecystectomy, near total cholecystectomy, leaving behind posterior wall, leaving behind a cystic ductum. But in elective cholecystectomy series, all these are considered as suboptimal surgeries. Okay, so can you justify that? So let us say that a confident surgeon is telling that I can come out safely, but with the partial, let us say 100 cases with the 5 partial cholecystectomy, 2 subtotal, 2 cystic ductum, many patients with a drain, and compared to another scenario of elective antibiotic therapy later, can we justify that? So that is my problem. So Dr. VARGHESE, I want to give what is your experience in those aspects?
No, we have actually the waiting period is too long, the 6 weeks of the waiting period. In between, the patient can have another episodes of, the same pain, etc. So it is, and these days everybody is so busy. They cannot postpone. The people coming from Middle East, they want to go back, and go back. They cannot wait for 6 weeks and, then hang around here for 6 weeks. So I think that it suits the modern world. And majority of the cases, what the problem, what you said, of course, it could be there related to subtotal cholecystectomy. Sometimes a retained stone can be there. And we had a couple of cases where we have gone back again, and then that the completion cholecystectomy later on. But that and all is not a common this thing. But definitely on the other side, that postponing the surgery for 6 weeks, definitely a lot of morbidity and involved. And as far as the patient is concerned, his problem is not solved. It's actually going on.
Okay. So Dr. Amit, I just wanted to ask you a one-word question. Do you agree with the aggressive surgical approach? acute cholecystitis, any time operate?
Dr. BIJU, probably I'm not the right person to answer it because aggressive surgical approach is not a feasibility in our center.
Okay.
So by default, all the cholecystitis are managed conservatively in our center, followed by biliary tract evaluation and then elective surgery. So I'm not the right person to answer this question.
Okay, so that is because of the logistics. What, Dr. AJO, what will you do?
Yeah, my policy is operate them when the diagnosis is made. Obviously there is a traditional 72-hour concept, but I think it is just because of the old time. We didn't have good imaging, good surgical techniques, experienced surgeons. So therefore, the morbidity was quite high with acute cholecystitis. So now with the improved technology, improved imaging, improved surgical expertise, we have reached a stage where acute cholecystitis can be operated even after 72 hours. So I operate all patients with acute cholecystitis, except if they, when the diagnosis is concerned, except they need some diagnostic workup, like if they have a high ASA, heart disease, lung disease, various comorbidities which needs sorting out, and they might need HDU planned care. But even patients with sepsis, with a significant organ failure, we drain the gallbladder, and the sepsis, when the source is controlled, we will be, when they are ready for anesthetic, we will operate in the same admission. We don't, obviously the problem is if you leave the patient with the drain for another 6 weeks or 8 weeks, the operation becomes more difficult. It's not going to become any easier. But so the acute cholecystitis is a beast. Obviously, it is not everybody's bread and butter. So the person who are operating acute cholecystitis is acute. I'm talking about acute cholecystitis. Yes. It is not like a patient had a biliary colic and showed some gallbladder edema, because any patient with a biliary colic, if you do a CT, it will show some edema around the gallbladder. That is not acute cholecystitis. I'm talking about acute cholecystitis with sepsis, with elevated temperature, elevated white cell count. Those are proper acute cholecystitis, and they need an experienced surgeon. If somebody operated the patient who found to be the operation this difficult, is better asking for a help rather than doing a subtotal cholecystectomy, which is suboptimal. And again, the problems are much higher, because some of the patients I operate are due to subtotal cholecystectomy with a few stones left in the gallbladder stump, which again come back as another acute cholecystitis. It's never going to stop. So it is important you make a good evaluation before the operation, patient assessment, good imaging, and also it depends on the surgeon's experience. And it's another cohort of patient has got abnormal LFTs. Some may present with a jaundice. I think those patients I would wait, because treat sepsis, sometimes even need a percutaneous drainage, and they need more imaging like MRCP. Or if their LFTs become resolved, then they will be taken for surgery with an on-table cholangiogram. So acute cholecystitis, it could be simple with just inflammation of the gallbladder, or it could be associated with other biliary problems as well.
Okay, so I think the things are becoming more aggressive. I understand correctly from what Dr. VARGHESE and Dr. AJO has summarized. Okay, another thing I wanted to ask Dr. TD. So, what exactly is anticipated difficult laparoscopic cholecystectomy? Here, you are evaluated the patient. There is no evidence of tumor as such and all that. Okay, so when will you say that this cholecystectomy is going to be difficult? Not a routine cholecystectomy.
In our discussion, you have witnessed many times that we discuss about predictors of difficult cholecystectomy, meaning thereby what are the which stone disease is going to have a more chances of conversion and bile duct injury. So I think this is the another component of same question. So okay, I have a very simple way of teaching to our resident. Start with the history, go to the examination, and then go to the imaging. So with the history of acute pancreatitis, history of acute cholangitis, history of ERCP, history of stent, even without having history of stenting, and then history of acute cholecystitis, where severe acute cholecystitis has occurred. So these are the people other than male gallbladder and this obesity. What we are talking about here in simple terms. So these are the people who are going to have on the history. If you are having this on the history, it is going to be a difficult gallbladder. Now coming to the examination.
Okay.
Every time we say, though we talked about component of the acute cholecystitis, where we did not discuss about the local signs. So I'm keeping it aside. A palpable gallbladder lump, meaning thereby if there is a mucocele, it is going to be a difficult gallbladder by the laparoscopy or open surgery. So now going to the third component, I have labeled as a cirrhosis also. Component third is everybody does an ultrasound. So on ultrasound, if there is a mucocele, if there is an impacted gallbladder at the gallbladder stone at the neck, if there is a chance of the Mersey syndrome, type 1, type 2 and 3 will be diagnosed basically. And if there is other like incidentally presence of the cirrhosis of the liver, which can be incidental sometimes. So these are the people who are going to have a small, thick walled, contracted gallbladder having no bile in it. So gallbladder packed with the stone, gallbladder stone impacted at the neck, mucocele presence, thick wall gallbladder having no bile in it. So these are the people on the ultrasound which are going to have a difficult cholecystectomy. So by the simple reason, but if there is impacted stone or there is a mucocele, the cystic duct becomes very small, and the length is smaller. So while dissecting in that area and giving a traction, there is a chance that we have a smaller. First is that CBD is small in size, small in diameter. Cystic duct is small in diameter. There is this impacted stone which decreases the length of the cystic duct. So very typical length, and that's why while dissecting there is a chance of the injury. So these are the sequence-wise: history, examination, and ultrasonography. All the three components, if it is there, it is going to be a difficult gallbladder operation.
Okay, so in this subgroup of patient, you expect a difficult gallbladder, go prepared, correct?
Yes. And we also request that if you are a beginner of the gallbladder surgery, you please have a request to some other person to give a backup or opinion opine. Dr. Kapoor says cholecography. There should be a colleague who will do a exam this thing. Yes.
Okay. So I will ask the same question in a different context to Dr. AJO. So he has spoken about totally anticipated difficulty. Now we have a situation where everything was normal. You went in. Now what are the situation where now after the scope is in, you are expecting a difficulty. So let us call it as unanticipated difficult cholecystectomy.
Unanticipated difficult cholecystectomy. This can happen because say a patient was on waiting list who had acute cholecystitis sometime with some other occasion, and ultrasound showed previous ultrasound showed acute cholecystitis, but later the patient probably had further episodes which we don't know, and they came for surgery. Then you start as laparoscopic, and then you use all your expertise to dissect to proceed with the operation. But I have a rule about 20 to 30 minutes. So if I am not making a reasonable progress in that sort of time, and I'm sure I'm operating for a gallbladder, no other related disease, okay, I would tend to convert the patient. Convert it to open cholecystectomy.
You will do an open cholecystectomy.
Open cholecystectomy. Open cholecystectomy is still accepted treatment, and the priority should be patient safety.
In that context, I wanted to ask you, is there anything very obvious? Usually anatomical abnormalities are not detected on pre-op imaging. what some suspicion of anatomical abnormalities which prompt you to tell on table that this is difficult?
No,
you
this is
diagnosis,
not.
But what will you suspect?
No, this is not due to anatomical abnormalities. It's technical difficulty because of probably some patients have got a cholecyst or a colonic fistula, other complications of gallstone disease. In that sort of scenario, or for a upper abdominal mass which is difficult to dissect, you're expecting malignancy. In those sort of either you abandon surgery or you convert. It is not unanticipated because the undetected anatomical abnormality, if you are doing a safe surgery, it shouldn't cause a problem. It shouldn't cause a problem because, always I say, you are doing a cholecystectomy, you stay on the gallbladder. If you drift away from gallbladder, that is when you run into these anatomical abnormalities, the ductal variant anatomies and all these. So, and again, if you cannot proceed safely as a laparoscopic operation, you should convert, because my conversion rate is around 3 to 5%, which obviously, I don't know, which may be okay in your standards, but I consider that is to make sure the patient is safe.
I think what Dr. AJO is telling very important. You should not just abandon the open cholecystectomy. Your data has to be always open cholecystectomy data has to be conversion has to be compared to the biliary injury data as well. How much is that? Then only that comparison. I wanted to ask Dr. VARGHESE, suppose there are difficult scenario. What are the options we have to do a safe cholecystectomy and come out in terms of partial, subtotal, whatever it is? What are the extra, or let us say, I call it suboptimal or whatever, but it is most of the procedures we know safe procedures. What are those options we have in a difficult situation to come out rather than abandoning the surgery or converting? Both you cannot abandon, you cannot convert. What are the options?
Yeah. One situation is that the gallbladder may be grossly distended and thick walled. Even your grasper, you find it difficult to catch on the gallbladder. You don't get a grip on the gallbladder. So in this case, it may be better to decompress the gallbladder initially. And also, then only very rare occasion now, as you mentioned now, we are not able to proceed with the cholecystectomy. We can convert that into cholecystostomy and come out. So the decompression of the gallbladder actually gives, the procedure makes it technically easier. So that is the first step. And the second thing is that the subtotal cholecystectomy is always, we know that, it is a recommended procedure in acute cholecystitis when there is a frozen Callous Triangle or the hilum or a combined frozen areas are there and the anatomy is not clear, then definitely it would be safer to do a subtotal cholecystectomy. And it's also it's said that in an attempt to do a complete cholecystectomy in this situation, the chances of creating bile duct injury is much more, which is a more dreaded complication compared to leaving behind a small part of the gallbladder there. Of course, some patients can come back with the problems related to that, but then it is much better than creating a bile duct injury. And here, the subtotal cholecystectomy is sometimes we come across a problem of where exactly you have to divide the gallbladder, because it may not be evident where exactly the gallbladder is finishing off, where exactly the CBD is there. So in those situations, what we do is that we open the gallbladder somewhere in the middle and then suck out all the contents and the stone, etc. And then we know exactly, then when we go towards the neck of the gallbladder, we divide. And then at a point where we know that, okay, the safe cuff of the gallbladder can be left behind, then we cut the transversely and the subtotal cholecystectomy.
So from inside you will look and see.
Yeah, we can have a look from inside. And in many situations, what we have to be careful is that, we have to correlate always the ultrasound findings. And these days, our sonologist report is so good. Almost all sonologists, they give excellent reports. So we need to see that the stone is there at the neck of the gallbladder. What is the size of the stone? Sometimes what happens when you go for a subtotal polycystectomy, then you miss out this stone. You are not taking out this, the stone is remaining there. And it is one way good because the patient would not have any leak in the post-operative period. But afterwards, they can come back with a problem. So we need to clear the stump out of the stones out of the stump 100%. That has to be done. Then the
stump has to be cleared. Okay.
Stump has to be cleared. And usually you can see that even though we talk about acute cholecystitis, sometimes the golden yellow bile coming out actually. So that is that means it's almost clear that you have cleared all of the stones from the stump. That is very, very important.
Yeah, Dr. Amit, I wanted to ask you, how often do you see the left out stump stones and presumed to be CBD stone, or the stones left out after cholecystectomy, not in the CBD?
It's very uncommon. I will say once in a year.
Okay.
And we are seeing at least 2 to 3 gallbladder stone for ERCP every week. Means not 2 to 3 in one unit. So it will be total around 10 to 15 gallbladder stone and CBD stone every week.
Okay.
So total, seeing the entire department, if I say, it will be not more than 3 or 4 per year. It is very less.
So it's very less.
Yeah, it is very less. And though you are finding a stone, but whether really this stone is causing a symptom is again a question.
Okay. Yeah. Okay. So I wanted to ask one question to Dr. VARGHESE as a continuation. Will you put a drain after cholecystectomy? So when will you put a drain? Just very, very relevant points. When will you put it?
No drain.
Okay.
But if there is when we are operating on acute cholecystitis, if there is the field is not clean, there was bleeding, or when you suspect, want to know that you are not 100% sure about your stump closure, so whether any bile leak will take place in the post-op period. So in those situations, definitely a drain.
Dr. AJO, when will you put a drain?
Now, the old days it used to say, if you are not sure, put a drain. But now, I think the last 2 decades it changed. If you are not sure, don't put a drain. First you sort out what you are not sure. So, so the indications of drains have changed, and I am a person against seriously against surgical drains, because my MS thesis was again about drains, and it caused lots of controversy in those days. So my view is, again, I stick to that. If I'm not sure about something, I will spend time and make sure I'm sure by myself. So if there is bleeding,
but a lot of surgeons are sleeping in the night just because of drain.
probably just that night. Probably just that night. Just that night. Yeah. The issue is, if you are not sure about something, you probably have to spend time and make sure you are sure. If you say with a difficult cholecystectomy, you have various problems after the operation. One, ongoing bleeding, which obviously you can, spend time. You can control. You can apply pressure. You can use diathermy. Even up to you can suture in cases where necessary. So bleeding is something you can control before you finish the surgery. That doesn't need a drain. And the next thing is a bile leak. Obviously, you may get bile leak from hepatic parenchyma. You can control it with a suturing. And the second thing is, if you are not sure about your cystic duct, that is the one indication, one thing. I totally agree with Dr. VARGHESE. In the last probably 1,000 cholecystectomies now, I clearly remember 3 patients I put a drain in, all because of unsure cystic duct closure. Because one patient, I ligated it it was started as a laparoscopic cholecystectomy, converted to open because of the difficulty. I sutured the cystic duct, but still his gallbladder was partially necrotic. So sutured the cystic duct, but I was unsure about the vascularity of the cystic duct. I had to put a drain in. But obviously, the drain didn't drain any bile. He recovered well and got discharged. I kept the drain for 3 or 4 days. The another patient was a laparoscopic cholecystectomy. I applied a ligature, which is the plastic clip, which is cut through the cystic duct. So I put a tie on the cystic duct, even though I am not certain about the, again, closure of the cystic duct. I had to put a drain in. Nothing happened. Third patient, the gallbladder just came off the cystic duct because of the acute cholecystitis. The part of that cystic duct was necrotic. So I sutured the cystic duct laparoscopically, and by the time I finished the operation, I was almost sure that the problems are sorted, but I was unsure that that will work. So I put a drain in, 2 drains. Usually when I put a drain in, I put 1 drain from the left upper quadrant in a straight drain into the, because that will go in a straight line into the gallbladder bed, and another one in the subdiaphragmatic area on the right side, and another one from the right upper quadrant, from the right upper quadrant port. So one of the drains drained a few mLs of bile for 2 days and then stopped. So I think the most common indication for putting a drain in is a suspected bile leak, I would say. Okay, because other complications you can sort out before the operation, before you finish the operation. But even if you put a bleeding, even if you put a drain, if the patient bleeds, you may have to do something about it.
Okay, so most of you do not prefer a drain, and if a drain is there, you anticipate a problem. That's what.
Anticipate. Yeah, again, there are more evidence is evolving that drain in surgery, especially abdominal surgery, is not a helper. It is actually, especially with the liver surgery, the recent evidence shows that it causes more infective complications. Okay, so we better stay away from drains.
Yeah, so Dr. TD, I just wanted to ask you, probably I am anticipating an answer from you in this. You have to send all gallbladders for histopathology. Am I correct?
Yes.
No question in that?
No, there is no question. Everybody should be sending it. And it's a very, very important, whether you are suspecting, whether you are not suspecting, whatever good is the ultrasound, we must send all the gallbladders for the histopathological examination, especially in this North India. One recent Swedish study has come up, but I don't think we can translate that thing in India, especially in Chandigarh, Ganges Belt, West Bengal, Northeast. I don't think we can have. Maybe you directed that question because I also looked at the study, but I think that is not for us, especially when we are working in North India and Northeast and East India.
Yeah, Dr. Varghese, you also send all gallbladders for biopsy?
Yes. I think that we need to send not only gallbladder, anything what we take out. I think we send
Dr. AJO also agree for that?
I send all gallbladders to histopathology, but there are hospital policies. My hospital doesn't have a policy. It is up to the surgeon's discretion. But there are hospitals with a policy where obviously you have to do the cholecystectomy and inspect the gallbladder. And if you are happy, then you don't need to send. But the issue is it's probably okay for Europe because the gallbladder carcinoma incidence are very low. But I think in situations where the gallbladder carcinoma prevalence is quite high, every gallbladder should be sent for a histopathology because you will find atypia or dysplasia and various histological abnormalities that will require follow-up. Yeah, one of my recent patients who had acute cholecystitis had a cholecystectomy, and histopathology specimen was a great surprise to me. It showed a dysplasia and areas of high-grade dysplasia. So that is possible because, yeah, definitely.
Yeah, Dr. TD, I wanted to ask you, just can you, 1 minute, can you just summarize what is an unsettled patient after cholecystectomy?
What is?
No, you said this patient is not doing well. What is that?
This what is our expectation? Like when we go for suppose we operate in the morning and go for evening round, the patient should have very minimal pain usually, and because of CO2 absorption, maybe a little bit of nausea and all. But in the morning, day one in the morning, patient should be almost walking up and about. Maybe some nausea, he still might complain, but there should not be any significant pain except that some port side pain. And this is something, if patient is telling you pain which you don't expect much like day one, usually we are not keeping BRE because you are doing daycare surgery, but we take the phone number and we talk to them in the night at 11 o'clock. I mean, this is our policy that our resident will talk to them. Are you having nausea? Any pain you are having? Any pain which is significant? Have you omitted? If not, then only continue. Otherwise, we call them. So I think pain is the most important feature, which can point you towards this thing. Unusual pain. Usual pain will be a little bit toward the port side, usually from where we are entering first. Lots of traction when you are doing an open technique insertion of the port. Then you are obviously doing lots of dissection there. That is the only port where there should be pain, and there should not be any usual finding in the abdomen. Patient should not be having this not passing gas and significantly more vomiting, which is usually not present on the day one. So if these are the pointers towards the something has happened, and I think minimum one ultrasound and one liver function test has to be done. And so before sending him, or if patient is gone home, call him and do all this imaging, at least be sure that nothing has happened, because as you are aware, in spite of all the efforts we are doing, still biliary injury have occurred. And there are people having thousands of gallbladder done, still they have caused the injury. So I think we have to be very, very careful. And then we should also think about what was the gallbladder during the surgery. Have you operated in a risky gallbladder? Our threshold to investigate would be more lesser when we are having a difficult gallbladder on the table. We all face sometimes, we are not very happy, but we still proceed. We take some calculated risk. So in a gallbladder where some calculated risk has been taken, in a gallbladder where little bit of partial cholecystectomy, as Dr. VARGHESE was telling, if you have done fenestration, you have done closure of the stem, then these are the patients where our threshold to go ahead with some investigation should be much more higher than compared to a little straightforward. So I think I have tried to summarize both components of your question.
Okay, yeah, thank you, sir. So my last question or point of discussion, I will address to Dr. VARGHESE and Dr. AJO separately. Dr. VARGHESE, if I ask you, what is the most important, if I say 2 points to avoid bile duct injury during cholecystectomy, just 2 points to avoid a bile duct injury during cholecystectomy? You are muted. Can you unmute?
Yeah. I think the first point is that, you have to accept that however experienced you are, you can still create a bile duct injury. So I think that the very fact that, we all are, we are potentially, able to make a bile duct injury. That itself will make us be more aware and probably try to avoid such a situation. And the other thing is that going near defining the junction between the gallbladder and the bile duct, that becomes a more serious concern in acute cholecystitis, frozen Callous Triangle, or at the porta, when the anatomy is not clear. So in these situations, you have to be double careful before cutting or making any definitive attempts. I think all help should be taken. In that case, I think we say that IOC in the intraoperative cholangiogram. But in this situation, intraoperative cholangiogram is very extremely difficult because it has also got a good learning curve. So it is not that easy in that. So taking help from a senior also definitely worthwhile in this situation if the help is around, or going near the gallbladder, the bile duct, if anatomy is not clear, should be avoided.
Okay, I'll pose my last question to Dr. AJO, the same thing. What is your most important tip for a safe cholecystectomy? Just in 1 minute answer.
Stay around the gallbladder. Don't dissect the callous triangle. Because people try to, I will share a picture if I can.
You're saying don't dissect the callous triangle, am I correct?
Yeah, I don't dissect the callous triangle because the callous triangle, you go very close to common hepatic duct. You stay close to the gallbladder. You dissect cystohepatic area instead of callous triangle. You stay around the gallbladder because people, even my colleagues, are still all the dictum of dissecting the callous triangle. If you listen to the lectures by Prof. The person from the St. Louis in Washington. Strasbourg, yeah. Strasbourg clearly stresses that point. You dissect the cystohepatic area. You start your incision on the peritoneum, on the gallbladder, and then go around the gallbladder to the opposite side, and then come down to the cystic duct. And then thereby you avoid injuring the bile duct, either common hepatic duct or a common bile duct, because especially in a difficult cholecystectomy, if you use more diathermy, what causes is a heat injury to the common hepatic duct, and later it can become a stricture, or even during the operation it can perforate.
Yeah, I think Dr. AJO told a very important point. Most of us are thoroughly frowned upon when we show a slide that what you should not dissect in a cholecystectomy is the callous triangle. Am I correct?
Yeah. Callous triangle, when you know the anatomy of the boundaries of the callous triangle, then you will realize. So it shouldn't be dissected, because traditionally that is the teaching. It is still a teaching. Because when the trainees come to me, first thing I teach them is, do not dissect, because even if my colleagues' operation notes, if I go through, the first sentence will be callous triangle dissected.
Yeah. Okay.
Probably they are not doing it, but obviously that has to, you have to stay away from callous triangle.
Yeah, I think last 1 hour, around 20 minutes, we have covered most of the issues related to gallstone disease, I think. So from the faculty or other faculty and audience, any pressing questions we want to ask or discuss with the expert and eminent panelists, we can have in another 5 minutes or so. So are there any questions or point to discuss?
So Dr. BIJU, till somebody is preparing question, can I announce about?
Of course.
Am I permitted to have an announcement?
Dr. Sunil sir, is it okay?
Oh, it's quite okay.
Yeah.
Okay. So IHPB Indian chapter, the coming meeting is scheduled in PGI Chandigarh on 6th, 7th and 8th of August 2021. So I had just typed the website www.ihpbindia2021.org. So now website is active, abstracts are being accepted, and registration is on. So kindly encourage your resident to send abstracts and get registered. Thank you. Thanks, Dr. BIJU and Dr. Sunil.
Thank you, sir. Are there any questions?
Hello, sir. Hello, good evening, sir.
Yeah, please continue. And please address to which panelist?
I'm Dr. Moni. I just want to ask Dr. AJO, if the callous triangle, or if the area is quite frozen, he said not to dissect the callous triangle. Could you just help me out how to proceed then? Like, if you want to stay away, then how will you know exactly, which is cystic artery, where is cystic duct? How will you proceed then?
So basically, you start your dissection on the gallbladder. You open the peritoneum. Especially in the acute cholecystitis, it will be difficult, but you will be able to identify the cystic artery in the normal landmark. Once you divide the cystic artery, you get more freedom because you will be able to dissect around the gallbladder to the opposite side. You also need to dissect from the lateral aspect of the gallbladder. From the medial and lateral dissection, you will be able to create that window. So that dissection is around the gallbladder, not away from the gallbladder, because the cystic the Callous Triangle boundaries are, one is common hepatic duct, other is cystic artery, and the third one is cystic duct. Am I right? So
Absolutely.
if you are absolutely, so if you go, because dissecting in the Callous Triangle is closer to common hepatic duct. Dissecting away from the Callous Triangle, just around the gallbladder, is far away from common hepatic duct. I was trying to share a picture which I was not able to. So I will try, and I will be able to clarify that. Just let me try once again.
Sure.
Probably what Dr. Ajay wanted to tell is, we are doing a cholecystectomy, just remove the gallbladder and come out, and don't worry too much about the anatomy and other things.
Then, so will not if you do that, most likely we will be doing a subtotal in those cases, what I believe.
No.
It is not. If I can share the picture, I will be able to do it. 1 minute.
Yeah, open cholecystectomies are generally done as a cholecystectomy. You remove the cystic duct as well. Traditionally, you flush cut with the bile duct, but the laparoscopic cholecystectomy era, you actually remove the gallbladder only. Cystic duct, you don't remove most of the part of the cystic duct. Cystic duct is just to the margin of the cholecystectomy. So that's a very critical point of shifting away from the Callous Triangle. So it's the wall of the gallbladder is your landmarks, and not the Callous Triangle. That's what probably Ajay wanted to.
Yeah, wall of the gallbladder is your landmark rather than yeah. Can you see the picture?
No, we are not able to see.
No, we are not able.
You're not able to. Anyway, that's not working. Sorry. Well, what I'm trying to say is, stay closer to the wall of the gallbladder. And once you have created the window under the gallbladder, along the inferior inner bottom of the gallbladder, then you can just dissect the tissues around the gallbladder towards the common hepatic duct, towards the Callous Triangle. So thereby you are widening the window along the posterior wall of the gallbladder up and down. So your dissection goes down will be to the cystic duct. So dissection going upwards along the posterior wall of the Callous Triangle, the posterior wall of the gallbladder will go towards the liver. So therefore, you basically are just staying on the gallbladder. You are not going near the common hepatic duct. So you are actually dissecting the tissues away from your dissection is basically on the gallbladder and cystic duct.
Okay.
So I think what Dr. VARGHESE, Dr. Ajay, and Dr. TD was basically pointing out, maybe if I am allowed to summarize that, in a very straightforward cholecystectomy, follow the outer wall of the gallbladder, and difficult once you approach the hilum of the liver, in difficult cholecystectomy, follow the inner wall of the gallbladder. So then, whether it is simple cholecystectomy or difficult cholecystectomy, your bile duct is saved. So subtotal cholecystectomy, all these options, you follow the inner wall in a very difficult situation, follow the outer wall in normal state, but nowhere in a safe cholecystectomy, Callous and other things are not a landmark. Do we have other questions? Yeah. There is one more question. When do you consider hepaticojejunostomy in CBD stones? So that question related to CBD stone, but Dr. TD, can you answer that? Just in one sentence, hepaticojejunostomy in CBD stone.
I just typed one answer at least, that if there is intrahepatic stones with the CBD stone, there CBD stone. So, but if you are finding lots of slurs with associated with the stone, and you are not very happy with the clearance of the CBD, and you think that there is a lower stricture, which is lower down stricture also present associated with the stone, and multiple failed clearance of the ERCP, then these are soft pointers. But intrahepatic stones will be definitely one of the indications of the doing hepaticojejunostomy to clear the stone, and then future also, in future, if there is a bile which is hypersaturated, as we said, which is prone for the recurrence of the stone, then probably it will be better to have a good hepaticojejunostomy. Otherwise, in today's era, the indications of hepatico have very limited. But Medicity syndrome, if it is there, type 2 and 3 and 4, then you might require hepaticojejunostomy in a case of query common bile duct stone, if there is a fistula. So these are the indicators towards the hepaticojejunostomy.
I think Dr. TD, you have one more question. I think the questions are directed to you only. Choledochal cyst with the stones and a dilated CBD with stones. Just 2-3 points how to differentiate. Very simple.
One very important, which every time we talk about, that intrahepatic undilated the system with the classical. If you talk classical fusiform dilatation extrahepatic and intrahepatic, there is no associated dilatation of the common bile duct, then that becomes a one important issue. Then we are having a good MRCP, and you are seeing that lower down there is an abnormal pancreatico-biliary ductal union, which says that there is a I'm not going into that details, but that is one associated abnormality if it is present. Only type 4 would be type 4A would be a little bit of confusing with this thing. Otherwise, this is important to understand that undilated system. Then choledochal cyst is always associated, most of the time associated with some sort of bile ductal anomaly, like posterior duct joining somewhere else. I'm not making a classical confluence. So these are the pointers which point toward the common bile duct stone, toward the choledochal cyst, in comparison to the CBD stone, where if there is a dilatation, and dilatation won't be that fusiform dilatation if it is very classical, because even cystic choledochal cyst may be associated with the stone sometimes because of the decreased flow of the bile. So one has to be very clear cut. One is that intrahepatic undilated system with extrahepatic fusiform dilatation or dilatation, and then abnormal pancreatico-biliary ductal union. These are the two main pointers. Then associated some anomaly may be hinting toward that. And usually 90-95% times you are able to differentiate. 5% times it still may be difficult. Then you have to take another many, like sometimes we try to take if you have drained the CBD, still dilatation is persisting. So there you might add HIDI scan, where there is because it become a receptacle. So usually the isotope doesn't flow, even if there is no obstruction. So these are the softer, but earlier two are the very important differentiating features.
Okay, Dr. Amit, you have a question, I think. Do we go ahead with the OGD scopy before proceeding to cholecystectomy GB stone with atypical biliary colic? Will you do that?
No, it's not needed.
Not needed. Not needed. Okay. You do not. Okay. Are there any other questions?
So, sir, I'm Dr.
Yeah,
Bipin.
please.
My question is, if there is
yeah, we are not able to hear you, Dr. Bivin.
Actually, Dr. BIJU,
yeah, please.
In continuation with the previous question, I can say, if we are dealing with CBD stone causing intermittent obstruction in old age person who is having some feature of malignancy like recent onset of anorexia, weight loss, in that case, not the OGD, but the side view endoscopy before surgery will be useful to exclude something at ampulla, periampullary tumor, uh, uh, which can mimic like stone disease sometime. And in stone may be a incidental finding.
So Dr. Bipin wanted to ask you, some questions. Can
yes,
you...
yes, sir. Am I audible?
Yes.
Sir, if the patient is having associated pancreatitis along with cholecystitis, whether it is due to gallstone or post-ERCP, what is your practice, BIJU, sir?
Okay, can you repeat that question?
He's saying pancreatitis in a gallstone-induced pancreatitis.
If the patient is having a pancreatitis along with cholecystitis, maybe due to gallstone or post-ERCP, what's your practice? Will you go directly for?
Yeah, we'll proceed. Dr. Amit will answer that question. I have a different opinion in that. It should not be followed, but Dr. Amit will answer that.
If there is pancreatitis due to any reason, whether it is post-ERCP pancreatitis or gallstone pancreatitis, then pancreatitis has to be managed first conservatively. And anyway, surgery will not be on the card at this time of point. First, pancreatitis has to settle down because acute cholecystitis can be managed with antibiotic with conservative treatment without much of risk of complication instead of going for surgery in a patient with pre-existing acute pancreatitis.
No, so then another question is, if there is a mild derivation of the enzymes, or will you classify it according to mild, moderate, or severe pancreatitis? Will you offer surgery for a mild pancreatitis?
No, even for mild pancreatitis, whatever be the severity of pancreatitis, what is mild today will remain mild forever is not sure. He may progress into moderate or severe pancreatitis after a week or 2 days of surgery, and then it will be very difficult for the surgeon also to manage because the complication may pile up because of pancreatitis. So first, pancreatitis has to settle down. There is no urgency of surgery in acute cholecystitis at that time. First, manage pancreatitis, let it settle down, manage cholecystitis with antibiotics, nil oral, painkillers, and then go ahead for the surgery.
Even if it is mild, Dr. Amit?
Yeah, even then if it is mild.
That was probably his question.
Can I say?
Yes. Yeah, Dr. VARGHESE and Dr. AJO.
Yeah, like I think what Dr. Bipin's distinct two different scenarios. One is a gallstone related pancreatitis. The other one, the post-ERCP. Actually, ERCP has been done for the clearance of the gallstone. So I think that regarding the gallstone pancreatitis, now as Dr. Amit said, the preference is for the management of the pancreatitis initially. But then if it is a mild pancreatitis and if it is subsided, then the laparoscopic cholecystectomy is offered in the same hospital admission before the patient leaves. But if it is a severe form of pancreatitis, definitely it is, it is delayed.
Yeah, Dr. AJO, you have a different opinion?
Yeah, I have it. Same but slightly different. But I suspect it is two scenarios. One is a post-ERCP pancreatitis. The post-ERCP pancreatitis is a completely different entity that is just treated as pancreatitis. If the patient has got gallstones, of course, gallstones need to be treated when the patient is ready for operation. If it is a biliary pancreatitis, whether it is mild or severe, the evidence is patient can be operated when the patient is ready for operation. It could be 1 week or it could be 4 weeks later. But when the patient is ready for the operation, the risk is low from the operation because you have to look at the list for surgical risk as well as the anesthetic risk. When the patient is, my recommendation, when the patient is ready for it is a multidisciplinary decision because if it is a mild pancreatitis and patient settled in 2 days, The same week you can operate the patient if the patient is ready for the anesthesia and the surgery. So that would be my view about pancreatitis. The other thing I wanted to, the previous question about the cholecystectomy, about Callous Triangle, I can show the picture if you have time.
Yeah, Dr. Sunil, can we have 1 minute more?
Oh, no issue at all. You can.
Yeah, please.
Yeah, I can share the picture now.
Yeah.
Are you able to see now?
Yeah,
Yes.
we can.
Yes.
Yeah, this is who was asking the question?
Yeah,
It was Dr.
was me,
Moni.
Dr. Moni.
Is he still there?
Yeah, I'm still here.
Yeah, see, this is Callous Triangle. Obviously, you can see in a simple, biliary colic you are operating, all this area will be very clear, and the operation will be more straightforward. But in a acute cholecystitis, you just think about if you are trying to dissect a Callous Triangle, you will be on the common hepatic duct. So my advice would be start your dissection here on the gallbladder, and you will be able to locate your cystic artery here. And then once you have divided the cystic artery, you dissect across to the opposite side of the gallbladder. You will have to dissect from this side, lateral aspect of the gallbladder, as well as medial aspect. It is an extensive division of the peritoneum starting from here up to the fundus. So just dissect the peritoneum all along, and the same on the medial as well as the lateral side. And then you will be able to create a window here. Once you have created the window wide enough, you can come down onto the cystic duct. Come down onto the cystic duct. And so,
can you tell where you should not dissect?
Whether you should not dissect within this triangle. That is where you shouldn't. Because if you go straight into the area first, you don't know where you are going. This is an uncharted sea, uncharted territory. If you start there, because I have seen many surgeons do a lot of low dissection. That is a Callous Triangle. That's a dangerous area. That is where you shouldn't dissect. Because when trainees come to my theater, they will say, "Oh, your dissection starts very high here. This area. This area." The thing is that when you do a cholecystectomy of biliary colic, you will see you divide the peritoneum here, you will drop down to here, and then once you have made the window, you will be able to push these tissues down, and then work along the cystic duct. Work along the cystic duct. These tissues will drop off, and then you create a window to the opposite side. You may be using a 30-degree scope. 30-degree camera will be very helpful for this dissection. You can see from both sides very well. In a difficult cholecystectomy, it would be recommendable using a 30-degree camera. Very helpful. So that is a picture.
Okay. Thank you for the nice picture. So Dr. TD was telling a cystic lymph node is surgeon's friend.
So I am telling because a friend helps you in your difficulty, and when you are in difficulty, you are not able to find where should I go. Then if you are able to see the cystic lymph node, it at least tells you that somewhere close to me is the artery, and stay lateral to me. Don't try to cross me and go medial to me. And that is one apart from all other points discussed. So I always tell our resident, now my friend is there when we are in difficulty. When you are not in difficulty, most of the time everything works. But when you are in difficulty, then your friend comes and helps you. And then I think one dissection is also very important. Apart from what Dr. AJO is telling. So in a difficulty, electrocautery should be absolutely not used until unless you are able to clear the anatomy. This is also
very important point Dr. TD was telling.
That is very important because the dissection I was talking about along the cystic duct. I preferably use some non-thermal instrument for that, because the area you have to be very careful because you are now coming down to the important structures. But you can use a lot of diathermy on gallbladder.
And
this is a scientifically proved aspect. Yeah, correct.
So little bit of using we can get away, but I see people start using cautery in the beginning only, and that is not correct at all. So we should not be using CAR-T until, as you said, your dissection will clear. Then CVS we have left. We clear the thing. You see, make the CVS. Then only you start using the organ. This thing. Somebody was saying. Somebody asked me a question: is harmonic scalpel good in a difficult situation? So it is also a double-edged sword. You can injure anything by harmonic scalpel. So I think it's important that the electrosurgical unit should be wait until unless you are very clear about the anatomy and you have cleared the CVS, you have seen everything as Dr. AJO has told. So having dissected everything, you are away from the Callous Triangle. Because the very important, because we teach our resident that nobody knows the temperature of the monopolar cautery tip. And how instrument, and in a magnification, we think that we are very away. But actually we are seeing 5 to 7, 6 times magnification.
Yeah, so that's a very important point actually, Dr. TD, you have to emphasize that because the distance of cautery from the structure, magnification, it looks very away, but actually it is very close.
Yeah. And the thermal, I asked my resident and Dr. BIJU till date, not a single, our JR has been able to tell. Then again, I have tell every time for 20 years, 21 years repeatedly, we are telling. Every batch we tell. But the transfer of knowledge is not that. The tip temperature of the monopolar, bipolar, harmonic, everything we should be knowing. So when we are using instruments, these are very important factors to prevent the thermal injuries and injuries crossing to the instrument also.
Okay, thank you very much. Dr. TD. Dr. Varghese, there is a question for you. 60-year-old male patient, umbilical hernia, planning laparoscopy mesh repair, screening revealed cholelithiasis, 9 mm stone. Will you offer cholecystectomy is the question.
No, the gallbladder is asymptomatic.
Asymptomatic only.
Asymptomatic. Yeah. Yes. My preference will be not to do the cholecystectomy along with the hernia.
Okay. Yeah.
But at the same time, if the patient is very insistent, then I will think of the option of doing it.
I have a question to Dr. Varghese.
Okay.
Dr. BIJU, I am Dr. Binny.
Yeah, please, sir.
For any asymptomatic situation, gallbladder stones like this, what you mentioned, does the stone size you take into account while deciding for a cholecystectomy?
No, it's like if you look. Yeah, if you look at the literature, the stone size about 3 centimeters is a real concern when you think of the association with the malignancy. But otherwise, lesser than that, it is not really justified. So
anything less than 3 millimeter? Anything less than 3 millimeter?
3 millimeter. Again, that way, if you see, we can justify everything and then do cholecystectomy for each and every patient. Because a small stone means it's a chance for slipping into CPD, Gallstone Pancreatitis. So we have to do. Right. Big stone means a chance for risk for malignancy. So we have to do. So everything we can justify and then do it.
Yeah, Amit is smiling because he's a small stone. He doesn't like surgeons.
Multiple small stone, then we prefer surgery because it can cause pancreatitis, cholangitis. As Dr. Varghese has rightly told, so anything, how you want to counsel, you can deliver on that direction actually.
Asymptomatic, I think we should not be operating unless there are special reasons for that. Even sometimes from the patient side also, they are so much obsessed with that, they wanted to get it out. I think in those situations, it's better to operate. That's what I feel, in those special situations. Otherwise, generally, prefer not to operate.
Actually, what I feel that for asymptomatic gallstone disease, other than size of the stone, the age of the patient is also important. In younger population, the contractility of GB is much more than the older population. And then the chances of stone being pushed out of GB and get stuck in cystic duct or CBD causing pancreatitis, all those are higher as compared to the those higher age. So that is also probably the one factor which we need to consider. If you see the other side, like he has rightly mentioned, 60-year-old, why the stone will grow to 3 centimeter or 2 centimeter? Because the GB contractility was less and there was longer duration of stasis, which causes the enlargement of stone. So probably stone size and the age of the patient. If you see the other side, if a person is 25-year-old, he is having still probably 50 to 60 year to develop complication. If the person is asymptomatic and 60 year of age, you have a shorter period of time when the complication can develop. So probably the age is another factor which we need to consider.
Yeah, Dr. Sunil, sir, I think
number of the asymptomatic stones turning into symptomatic, it is roughly 2% per year.
Yeah, again, so the same, the risk will be higher for the younger population.
That way, younger patients stand more chance to develop problems compared to older patients.
Exactly. The complication risk will be higher because the duration.
I think the concern raised by the person who asked the question, Dr. Jeevan Jose, is that you are placing a mesh into the abdomen.
Yeah.
And then subsequently going through the mesh, could it be a problem? Subsequently, when it develops a problem. So that must be a reason why he's asking. But at the same time, supposing there is a spillage of bile, and then you can't do the mesh repair in the first instance, that is also a problem. So,
Sunil,
it's a really
in that
situation.
Sunil, in that scenario, you could do two ways. One, obviously, if it is straightforward cholecystectomy, you are anticipating, you can repair umbilical hernia and take the gallbladder. But if you don't want to do the cholecystectomy, you do a supraumbilical port and then do the cholecystectomy and do the umbilical hernia later. Or if the patient is totally asymptomatic from gallstones, leave the gallbladder alone. You can repair the umbilical hernia, and if the patient becomes symptomatic later, you still can operate through a supraumbilical port away from the umbilical mesh repair.
So whatever the approach, you need a good counseling either way, because supposing you land up with problem, the patient really has a symptomatic hernia, and you are going to say, I did gallbladder, so today I will not be doing your mesh repair because I had some spillage of bile. Then he might start thinking.
How do you extract your gallbladder? Do you use a bag or the port? Bag. Yeah. So you can use an endo bag. Yeah. You put in the endo bag and take extract, which should be fine. And then you can repair the hernia in the same sitting. And give antibiotic prophylaxis.
So thank you very much.
Another option is to do the hernia by a small subumbilical incision.
Open technique.
Open technique. And the supraumbilical port.
That'll be better.
Yeah, I'm talking about open umbilical hernia repair.
No, the question is about laparoscopic mesh repair.
Yeah, laparoscopic.
No.
I think the concerns are there. As Dr. Sunil says, patient would have come with a problem of hernia, and then finally you are not able to do the hernia. You have done the gallbladder.
Exactly.
Dr. Sunil, sir, I think
we are coming to it. Thank you.
Okay.
Thank you.
Okay.
Thank you.
Bye.